In this recording, we're going to kind of tie things together. We're going to use some of the information that we learned about when we looked at, say, regulation of cardiac output and apply it to exercise as well as some abnormal conditions. So during exercise, people can increase their cardiac output by quite a lot. Trained athletes definitely. So trained athletes can increase it by, like, say, 700%. So we're going to look at, well, what are the things that can allow us to increase our cardiac output during exercise? But first, I want to mention what cardiac reserve means. So cardiac reserve is really the difference between your resting cardiac output and the max cardiac output that you can achieve. So a trained athlete, their cardiac reserve is going to be much greater than, say, me. So if you think about, say, someone with a valvular defect or some other heart issue, that their cardiac reserve can be severely diminished, and so their ability to exercise may be affected because they're not going to be able to increase their cardiac output like they would normally have. So let's just look at what are the ways that cardiac output increase during exercise. And I'm going to use this picture, and you can always pause this to fill in this diagram and then come back and listen to what I'm saying about kind of the link to exercise and cardiac output. So I'm going to look at this picture and kind of talk about different things that are involved during exercise. So if you're exercising, you're definitely in a fight or flight mode. You're in sympathetic mode. So the autonomic nervous system, the sympathetic nervous system, will be increasing your heart rate. Remember, norepinephrine is released by those nerve endings, binds to those beta-1 adrenergic receptors, and through the effects on the T-type calcium channels and also L-type calcium channels, which, well, actually we'll say the T-type calcium channels, it's going to increase your heart rate. When you're in that sympathetic mode, the effects on the L-type calcium channels will be linked to that increase in cardiac contractility. So you have both an increase in heart rate and cardiac contractility because of the sympathetic nervous system. And you can add in the effects of epinephrine and norepinephrine that's released by the adrenal medulla when you're in sympathetic mode. So they bind again to the beta-1 adrenergic receptors in the heart and lead to both an increase in heart rate and contractility. And so again, look at this equation. If I increase heart rate, increase stroke volume. So if you can increase contractility, you will increase stroke volume, cardiac output would go up. The effects of volume on heart rate as well as contractility. When you're exercising, you're going to have increased skeletal muscle activity, and that actually helps to increase venous return. It's going to make sure that blood is going from your veins up to your heart. And so it's actually, we call it, a kind of a pump. So the skeletal muscles around that are contracting around those veins help to ensure venous return. And as venous return increases, because of that Bainbridge reflex, as well as I had mentioned previously, atrial stretch, you'll have an increase in heart rate. So remember, atrial stretch, you're just stretching those P cells. You get a 10 to 15% increase of heart rate from rest. Bainbridge reflex, which is mediated through your nervous system. So the vagus is delivering that sensory information to the cardioregulatory center in the medulla oblongata. As a result of the increased blood in the right atrium, as a result, you have increased sympathetic nerves, activity to the heart, and you'll have a reflex increase in heart rate. The venous return also will affect your contractility. So that is, remember, the two things that determine end diastolic volume is your venous return, the stuff that's coming back to the heart, as well as what was left over from behind. But we're going to have definitely an increase in venous return. That increases end diastolic volume, and because of that Frank-Starling mechanism, that more in, more out, you'll have a more forceful contraction that will increase your stroke volume. Your blood volume, and technically when you're in sympathetic mode, you will have constriction of veins to make sure we have more blood in your arterial system during exercise, and that will increase venous return, which again will increase heart rate as well as cardiac contractility. Now, depending on the type of exercise, you may get vasoconstriction or vasodilation, but say when you're running, doing any type of aerobic exercise, isotonic exercise, is you'll have peripheral vasodilation because of the buildup of metabolic byproducts, and vasodilation will increase venous return, which again increases heart rate as well as increase cardiac contractility. Now, if you're doing an isometric exercise, where say you're doing a static squat, you're like do a wall sit where you can't be moving, so you can't really do isometric exercise for very long. But if you do isometric exercise, you'll have vasoconstriction, and the thing is that will that's going to place a huge load on your heart, and it leads to what we call a pressure reflex. And because it's saying I'm not getting blood to those vessels, and so blood pressure actually can go up quite a lot, but you're not going to have increased blood flow to those muscles. So we're going to stick with isotonic exercise, and you get peripheral vasodilation. Now, the filling time, you're going to have reduced filling time, but for a very large range in heart rates, we get enough blood in there to be able to sustain an adequate cardiac output. So I'm not going to mess with that. During exercise, let's see, we have, I think I covered the main things that'll be important, say, during exercise that allow us to have that pretty good increase in cardiac output. Now, the biggest things, the biggest factor for cardiac output is stroke volume, though. That is going to be a more efficient way of increasing cardiac output, is increasing stroke volume versus heart rate. You don't want to have to pump so many times. If you think about people in really good shape, when they're exercising, their heart rate doesn't get anywhere near of what someone who's out of shape. They have a very effective cardiac contractility. They have large blood volumes. They don't have to get their heart rate up as much. Okay, so I just want to leave it at that. Now, a couple things I'm going to look at is some abnormal conditions that affect cardiac output, but I'm going to do some terminology first. Is if someone has, we say, a hyper-effective heart, that means it's more effective. It's a more effective heart. To some extent, hypertrophy can make the heart hyper-effective, and say in endurance athletes, they do have hypertrophy of the heart, and it's pretty much, and we call it eccentric hypertrophy, and we've mentioned that term before, is they have to accommodate larger blood volumes. Concentric hypertrophy is not the way to go because you're not going to be able to accommodate a good amount of blood in those ventricles, but hypertrophy to an extent can make that heart hyper effective. And also athletes, especially those elite athletes, can really get kind of the mass sympathetic response. So they can get a heightened sympathetic response. And so the sympathetic stimulation with the hypertrophy, the larger blood volumes, that's going to make their heart be able to be more effective. Hormones definitely can make the heart more effective, like epinephrine and norepinephrine released by the adrenal medulla. A heart that is hypoeffective, no one wants that. That's a bad thing. Is if you have insufficient blood flow to the heart, you're not going to be able to deliver the oxygen and the nutrients for that heart muscle to be able to work effectively. If you don't have oxygen, not good either. So the heart really needs to work aerobically. So they would make the heart hypoeffective. Any of the valvular defects can make the heart hypoeffective. What's going to be similar with all of them is where they're going to affect the heart is they affect stroke volume. They can result in decreased stroke volume. And I'm going to look at that again in a little bit. If you inhibit the sympathetics, that would also make the heart hypoeffective. So we can have a hypereffective and a hypoeffective heart. We're actually going to look at things that make the heart hypoeffective. Calcium channel blockers. These are drugs that block calcium channels, and there's a wide arrangement of, or say a wide array of different calcium channel blockers. Some of them target the T-type calcium channels, some target the L-type calcium channels. They all in some way, shape, or form, either directly or indirectly, could decrease contractility, affect conductivity of the heart, and also affect heart rate. But typically what calcium channel blockers have been used for is to, and when we're talking about the heart, is to decrease the workload that the heart has to do, decrease the demand that heart has for oxygen. But a side effect of these is a decreased heart rate, bradycardia. So bradycardia is, remember, a heart rate that is less than 60 beats per minute. So that could, if it gets too low, that could cause problems with someone. But these drugs are typically were given. It's also given for to cause vasodilation, because calcium channels are very important in smooth muscle contraction. But just as a frame of reference, that verapamil is a calcium channel blocker that affects T-type calcium channels. This one affects the L-type. So the L-type, or that long-lasting, that affects that's the DHP receptor. So that's the one that's responsible. So I do this for that when you're looking at, say, the action potential and that ventricular muscle for the opening up of those L-type was important for that plateau phase. The T-type were more important in, say, heart rate. But the blocking calcium channels will affect, any type of calcium channel will affect contractility also, as well as heart rate. Now, the beta blockers, as a rule, lots of times if you ever see a medication that ends with this, it's a beta blocker. And there are specific beta blockers and there's non-specific beta blockers. The specific ones will block specifically the beta-1 adrenergic receptor. Non-specific will block other beta adrenergic receptors like the beta-2 adrenergic receptors. Now, specifically, just so you know, atenolol, this is cardiospecific. So this blocks the beta-1 adrenergic receptor. And propranolol is non-specific. So they say non-cardioselective. So that can affect the beta-1 as well as the beta-2 adrenergic receptors. Now, since the beta-1 adrenergic receptor is on the heart, it's on the SA node, it's on that ventricular muscle, if you prevent epinephrine or norepinephrine from binding those receptors, that definitely is going to increase heart rate. It's going to decrease heart rate, decrease the cardiac contractility, which would decrease stroke volume. They do also affect conduction through the AV node too. So these are, again, often given for high blood pressure. They're also given sometimes to decrease the workload of the heart on a patient. A very long time ago, they were trying to evaluate me. I was having a lot of arrhythmias, and I was in the hospital, and they gave me some beta blockers because they were trying to decrease the workload of my heart. But I was in bed, and so it was decreasing my heart rate quite a bit. And so it's good I was in bed because I probably wouldn't be able to stand up. I have low blood pressure to begin with, and so it can, beta blockers can, with patients, you're going to have to watch the dosage, can lead to bradycardia and decrease blood pressure. If it's too low, they're going to pass out. There's some other things in here. There are always going to be side effects of drugs, but you can kind of look at it. But beta blockers are very commonly used. Another drug I wanted to mention is digitalis, and you may hear it called digoxin. It's derived from the foxglove plant, and digitalis is a drug that decreases heart rate but increases cardiac contractility. So I'm going to show you how it increases cardiac contractility. So it was typically in the past was given to try to increase the cardiac output in people with heart failure. And I had mentioned previously, it's more important to increase stroke volume than increase heart rate. So they were trying to decrease the heart rate in these people, but increase cardiac contractility. And what that drug does is it blocks, or not blocks, it kind of inhibits the sodium potassium pump. And you gotta be real careful with that, because that pump is so important in a lot of things. So they have to really, really watch or when they they don't really use it much anymore, but it does have cardiotoxicity. Is what happens is, if you look up here, this top picture, is by way of that sodium potassium ATPase working, is you see it creates a gradient, a favorable gradient for sodium over here to want to come in here and to get calcium back out of the cell. And if getting calcium back out of the cell is important after you've had the muscle contracted. Now, if you inhibit that pump, what happens is it switches. Look at this. It switched the direction of that sodium-calcium exchanger. And so you see calcium coming into that cell, and it's going to allow us to have more calcium available inside that cardiomyocyte. And calcium is really important in contractility. And so it was able, using this drug, that was able to increase cardiac contractility. Now, its effects on heart rate, they're kind of like, it's what they believe is why it decreases heart rate is it affects the vagus. It decreases, or it should say, it increases the firing of the vagus nerve. And when you have increased vagal firing, that decreases heart rate. So that's what they believe is why it causes a decrease in heart rate. Now, a couple of ion imbalances I want to mention. Just think about ions, especially potassium and sodium and calcium. Those are extremely important in membrane potentials or muscle contraction. And so if you mess with the levels of those ions, either too much or too little, it's going to lead to some dangerous arrhythmias. And you notice here, this guy's bowels don't look right either, but it's going to affect other organ systems. But here we're just kind of dealing with the heart. Just to kind of give you a couple examples. If you have, hyperkalemia where you have too much potassium in the blood, that could lead to, and I'm not going to go into the nitty gritty, but I'm just going to tell you what it can lead to. It can decrease heart rate and the force of contraction of the heart. So obviously decreasing both of those, that's going to affect cardiac output. Calcium can affect it. So if you have, say, hypercalcemia, so too much calcium in the blood, what that can do, you're like, oh, this is a good thing. It can increase contractility of the heart. You're like, oh yeah, that's pretty good. But it could increase the risk of prolonged contraction. So I'm going to write that. But increases risk of a prolonged contraction where then it doesn't relax. It's a sustained contraction. If your heart is in a sustained contraction, it's not going to fill up with blood. So this is not good. So prolonged contraction. So hypercalcemia is very serious. If you have hypocalcemia, too low calcium in the blood, that would be associated with decreased contractility. And as a reminder, the heart relies on calcium from the extracellular fluid as well as calcium inside the cell and within the sarcoplasmic reticulum. And so if you don't have sufficient amount of calcium in the extracellular fluid, that's definitely going to affect that contractility. So that calcium is coming in through those DHP receptors or those L-type calcium channels. It's going to be very important for contractility. And to kind of tie in something from the ECG is with short QT syndrome, that can result from hypercalcemia, and hypocalcemia can result in long QT syndrome. Say wrong. So as a reminder, PQRS T, the QT interval is here. So they can affect the calcium levels in your blood, can affect the QT interval. Now, a couple other things I want to mention. Temperature. Increased temperature increases the permeability of the membrane. It's associated with an increased heart rate. Decreased temperature is associated with a decreased heart rate. Valvular defects. What else I want to do, I'm not going to do cardiac conduction problems. I'm going to do valvular defects. As a rule, the valvular defects in one way, shape, or form can be associated with decreased stroke volume. You're not going to be able to have an adequate stroke volume. With people with relatively minor valvular defects, or it doesn't even have to be relatively minor, is you may have someone with a valvular defect that has a decreased stroke volume, but their cardiac output is perfectly normal, because cardiac output is stroke volume times heart rate. So if the stroke volume is low, the way I can keep this to be normal is you'll see they have a higher than normal heart rate. So they'll have higher heart rates than normal just to maintain adequate cardiac output. Now, if that cardiac output gets too low and your heart rate can only go up so much, definitely you're going to have some issues. Cardiac output, you're not going to be able to get enough oxygen to your tissues. It'll affect your blood pressure, because we'll be looking at blood pressure when we do circulation. So the valvular defects can affect your cardiac output. So we're going to leave it here. And if you have any questions, just feel free to ask.